So I just want to quickly talk about really three things in the rest of the talk this afternoon. The first is the where we've got to, in a sense, in terms of the growth of for-profit healthcare in the UK. The second is, how did we get here? And then the third is, what are, you know, the consequences of that for patients and also for medical practitioners and others working within the system. So I think just to give you some kind of key facts about where we are, and I'm sure that the audience here probably knows these as well as anybody, but I think it's sort of quite useful to reiterate some of them. So in 2021, for the first time in history, and this was partly due to the pandemic, but I think it is a relevant statistic, that more hip and knee operations were carried out in private facilities in the UK than in the NHS. Now, some of that, as I say, is due to the backlog of care and the fact that the NHS was dealing with COVID patients and other types of patients and couldn't provide those types of services. But it did mark a sort of shift away from the idea that the NHS was the dominant provider of orthopedic care. Now, that is likely to switch back towards the NHS, I would guess, over the next few years, but that is part of a trend which has been occurring over quite a number of years. Secondly, it's now the case that most cataract operations are provided on a for-profit basis in the UK, and that's both cataract operations that are paid for privately by individuals or by insurance companies, or as a result of a lot of the significant outsourcing of NHS ophthalmology services since 2019. We also have a situation where there's £2 billion in investment in new private hospital facilities from overseas investors has occurred since around 2014. Now, if you think of the extent to which the NHS capital investment strategy has all but collapsed over the last decade, to see that amount of money coming into new private hospital facilities, that includes the £1 billion Cleveland Clinic in London, but also a number of other smaller and quite significant hospitals and eye surgery clinics, chemotherapy centres, not just in the southeast of England, which is traditionally where lots of the private sector is operated, but throughout the country. So I think some of those facts ought to give us a bit of an indication of the fact that for-profit healthcare is growing in England, and that the trajectory looks like it will continue to grow. There doesn't seem to be very much pessimism on the part of overseas investors that there won't be opportunities to make a profit out of healthcare in the UK in the years to come. The next thing really that we need to kind of have a bit of an understanding about is how has this happened? Because it's often the case when people start talking about things like the two-tier system, which is emerging, where people have either the choice to pay privately for their hip operation or cataract operation or other operation they can't get on the NHS, or they're forced to do so because the NHS services aren't available, that the facilities, the ability for the private sector to actually deliver those operations hasn't just been magicked into existence over the past couple of years. It's been part of a process which has been occurring really for the past 10 to 15 years or longer. And I think it's important for us and for the public to understand really how that for-profit healthcare sector has grown in the UK, because much of it is due to government policy. So going back to the introduction of independent sector treatment centres in the mid to late 2000s, you know, what we saw there were significant subsidies provided by government to enable the private sector to come in and deliver NHS operations. Now, at the time, that provided, the state provided a significant subsidy, around 350 million, to permit those centres to operate and be profitable. But also, and people don't often recognise this, that was the moment in which 3 of the large for-profit providers in the UK, Ramsay, Spire and Care UK, actually took off. So you can trace the seeds of the growth of those companies back to the ISTC programme. So you had significant state subsidy there. You've also got state subsidy in a slightly different and hidden way, which is in relation to the permission that is given by the NHS to allow the private hospital sector to use NHS consultants without paying anything for their training, without actually even employing them directly, so therefore not having to contribute any national insurance costs. We estimate that that works out as a free good to the private hospital sector of about £7.5 billion. In addition, the NHS will always pick up the pieces when something goes wrong in the private sector. So during the pandemic, despite the fact that the private hospital sector was supposed to be there to support the NHS, we know that around 6,500 patients from the private sector were treated in NHS hospitals. And this is because private hospitals don't need to have in place any of the intensive care facilities, because they know that the NHS will pick up the pieces, and they do this free of charge. So we estimate that costs the NHS around £70 million a year to treat patients who've been transferred from private hospitals to NHS hospitals. We also know that the income streams which a lot of the private investors who are looking to enter into the UK healthcare market are able to rely on comes from referrals from of NHS patients. So between 30 to 80% of the income of most of the private hospital companies in the UK comes from treating NHS patients. And the fact that this income stream has been very reliable over the past decade, really since Choose and Book and the e-referral scheme was introduced, means that the private hospital sector that is expanding and growing in the UK has many of its risks underwritten, because it almost has a kind of guaranteed income there, which will cover off some of the costs of investment. We've also seen at different points during the history of the growth of the for-profit healthcare sector in the UK, in some cases almost direct financial support given to the these companies. One of those instances that is forefront of our mind at the moment is the £2 billion contract between the NHS and the private hospital sector during the pandemic, for which the NHS itself didn't receive very much in return. However, that £2 billion very much kept a lot of the private hospital companies financially afloat. And I think the final issue which we've really got to start thinking about in terms of the trajectory of the NHS is this issue that I'm sure you've all been discussing today, and also for a number of years now, is the managed decline of the NHS. Because when you look through the strategy documents of lots of the companies that are looking to invest in the UK, the companies' strategies who are already operating here, they have in effect been betting against the NHS. So even though they rely substantially on the NHS, both of the workforce, in some cases for direct subsidies and also for their income, they also see that the NHS is going to struggle to meet the population need because of the amount of money which is being provided to it by the government. And this means that they can invest in new facilities on the assumption that there will be a growing number of people who will have to pay for their own care, who will have to pay for their own operations because they can't afford, they can't access NHS care. And I think that's a really crucial dimension to this, because it's not just that, as I say, the private sector has suddenly emerged from the pandemic in a position to capitalise on the managed decline of the NHS. This was thinking which goes back to 2017, when the writing was on the wall very much that the amount of money which was going into the NHS and the political will to keep funding the NHS to the level that was required meant that these companies were aware that there would be a growth in the private pay market. And since 2019, we've seen 193% increase in the number of people paying out of their pocket for hip operations. So at the moment, the bet that the private hospital sector and the for-profit sector has made seems to be paying off. I think it's important, once having sort of spoken about where we've got to and how this has happened, to actually reflect on what this means for the founding principles of the NHS. Because again, going back to that discussion around the privatisation of the NHS and what it actually means, we often end up caught in this discussion about what do we mean by privatisation? Why is it a bad thing? What are the kind of the reasons why anybody should find this problematic? I think it's important from our perspective to be trying to inform people that there are dimensions to the growth of the for-profit healthcare system in the UK, which has direct impacts on how the NHS operates, but more generally about the type of healthcare system that we have. So the first of those, and I think ophthalmology is a very good case study, because what we're seeing at the moment is large outsourcing of services, particularly cataract services, which has the potential to hollow out NHS eye care departments. And this leaves these eye care departments both short of consultants who are leaving NHS eye care departments to go and work for private companies. They get paid more, the conditions are easier, and it also then leaves the eye care departments both without the income that comes with the provision of cataract services, but also without the consultants. And this leaves them often unable to treat complex NHS patients. I think that's a really important example of how the shift of service provision out of the NHS to the for-profit sector has that ability to hollow out and undermine particular functions within NHS hospitals. The second dimension of this is that once you start moving towards a two-tier healthcare system, because there is a functioning, growing, vibrant for-profit healthcare alternative, you then impacts on the ability to continue to raise taxation in order to fund the NHS. And I think it was Peter Townsend, the social policy expert, who argued that once you have a situation where services, healthcare services, social services are only for poor people, they end up being poor services. So this idea of people opting out of the NHS to pay for their care is deemed in some quarters to be a way in which the burden can be alleviated from the NHS, is actually over the longer term likely to undermine that aspect of the social contract which enables people to feel as though by virtue of paying their taxes, there will be a service available to them, and therefore they'll continue to invest not just financially in the idea of the NHS, but also in the founding principles of the service. So that's a second big risk, we think, to the founding principles of the NHS. Finally, I'd just like to say that in addition to the dimensions to the founding principles of the NHS, which come from the growth of the for-profit healthcare sector, there are also particular risks to patient safety. And we've identified these on a number of occasions, and it's not just been us, it's been coroner's inquests, it's been public inquiries, it's been regulatory bodies who have all shown that there are systemic safety risks in the private healthcare system which have the potential to put patients at risk of harm. So as more and more patients go down the route of for-profit healthcare, particularly in the private hospital system in the UK, the risks to patient safety grow. The second dimension as well, which is related to how doctors operate within the NHS, is that there is a change in the ethical framework once you start seeing a growth of for-profit healthcare. And we've documented in a number of instances the significant number of NHS consultants who have joint ventures with private healthcare companies. And this arrangement, often with large American owned healthcare companies operating in the UK, has the potential to create conflicts of interest between the patient's interests and the doctor's own financial interests. And that's a huge shift, because for a large part of the NHS's history, we've managed to insulate the doctor-patient relationship from anything to do with the profit motive or anything to do really with the financial concerns of those providing services. So what do we need to do about this? I think each organisation that is concerned about the direction of travel have got different roles to play, and I think KONP is a very important organisation to be mobilising and bringing people together to challenge the direction of travel. Our role primarily, and again, one of the reasons why it's useful for me to be able to speak to you today, is to help inform people about these developments, not just in terms of the actual data that we're able to gather, but primarily because of the risks to the founding principles of the NHS.